واحد sharp mousse. Now we want to reconstruct this wound, and we need to know the layers. Then don't look for deep fascia. Almost every part of the body has a deep fascia except the face. This is also a lesion of the face. It doesn't look nice because of irregular margin and black dot. This is also suspicious area because of irregular margins and black spots. This is more suspicious lesion because of elevation, dark areas of hemorrhage. So we have to suspect something bad. Again, irregular margin, irregular distribution of color, which is not very nice. Suspect something bad. This is a bad lesion, cancer of the face. This is also a manifestation of some systemic disease. This is very severe and bad acne. This is more severe case of leprosy. You know leprosy. Therefore, many of these lesions require us to know lymph drainage of the face. It's a very important issue. It's going to be submental, submandibular, pre-auricular, post-auricular, superficial cervical, supraclavicular, and deep cervical lymph nodes. Whenever you have any of these lesions, go and examine these lymph nodes, which you know when you studied your hemolymphoid system. This proved to be a very big lymph node. اللي بده يطلع اللي هو Mr. or Miss 10% اللي يطلع بسرعة. ما شاء الله. روح تعلم ميديسن برا. روح تعلم ميديسن برا. You know, you are a headache. When you go out, you stop having a headache. أحب أذكركم أن لما تروح سنة رابعة وخامسة وسادسة الزلمة فيهم يطلع من نص المحاضرة. الزلمة فيهم يطلع من نص المحاضرة. Anyway. This is a scar of a wound. Fair enough. This is a bad wound. And it has to be covered cosmetically. I will be leaving you with this mind map on your e-learning. This is a big problem. A periorbital edema and hemorrhage. Eyelids, many structures around the eyeball. Now, the story starts here. A boil on the nose. Pus, if it is squeezed or pulling a hair out of the external part of the nose. these areas are within a triangle called dangerous triangle of the neck. It involves the root of the nose, the dorsal part and the sides of the nose, the tip and the upper eyelid. This is the dangerous triangle of the nose. Why it's dangerous? Because if infection is introduced into this triangle, and especially if it's squeezed, you see when you squeeze something, pus comes out, but the same quantity goes in the interstitial tissue, picked up by the veins, and it travels through superior ophthalmic vein and inferior ophthalmic veins, and it goes to the cavernous sinus. And you know that the cavernous sinus has cranial nerves traveling in its lateral wall. Infection may go in the vein, not directly through the ophthalmic veins, but indirectly through this plexus, which is called pterygoid plexus of veins, around pterygoid muscles in the infratemporal fossa. And again, from less probably from other areas in the face, and indirectly they go to the cavernous sinus. And this is this cavernous sinus exposed to the danger of infection, and it is difficult problem. Now, these veins of the face are what? They are valveless. That means blood is not traveling in one direction. Blood can change its direction. This is another case of cavernous sinus thrombosis, periorbital edema. Can this be cavernous sinus thrombosis? The answer is yes. Now our story begins here. Patients generally have mid-face infection in the dangerous triangle or sinusitis. Patient comes saying that he has headache, fever, and periorbital edema. Headache and fever can happen with many things, but periorbital edema is pointing to something. And cranial nerve signs. You know what are cranial nerve signs? Change position of the eyeball. So periorbital edema and cranial nerve signs are very indicative of cavernous sinus thrombosis. Some cases present with only focal cranial nerve abnormality. So if you have a question in the exam saying, a young girl who developed fever, complained of headache, the eyelid was little swollen, right? And the swollen eyelid, when was lifted, she has a little or a partial cranial nerve 3 injury. This case is likely to be what? Cavernous sinus thrombosis. So test cranial nerves. This is an MRI of a normal cavernous sinus. That's the pituitary fossa. And this is a bad cavernous sinus with meningioma. So we need to activate our knowledge in the veins of the head and neck, arteries of the face, and muscles of facial expression. And we're going to use this piece of information. These are muscles of facial expression, and we need to activate our knowledge, and we are going to reuse it and apply it. This lady has this wound extending from zygoma, lower margin of the eye, and the root of the nose. We say these are muscles of facial expression. Sorry. This is possibly the line of the wound. If you suture this wound without knowledge of muscles of facial expression, you are suturing muscles together in one bite. So this lady, when she's asked to close the eye, that means it uses orbicularis oculi. Now, her lip, the zygomaticus major and minor, they are involved in the stitch. Whenever she closes her eye, her upper lip goes up, and nobody likes that. It's because the doctor has no idea what are the muscles of facial expression. In this patient, you can see that there is a wound extending from the angle of the eye towards the zygoma, and this is the possible site of the wound. If the doctor sutures the orbicularis oculi with the temporalis, whenever this person is going to eat or chew, the angle of the eye is going to move. Very unpleasant. And so many examples. So we need to reactivate our knowledge of muscles of facial expression. It's important that we know individual muscles. This figure is telling me that these are the lines of Langerhans, and if I am going to make a suture, it should be along these lines. But traumatic wounds, they don't follow. So we suture them and we expect bad scars. This is the nerve supply of the face, because in a neurological exam, which we'll be doing next year, say, examine sensations of the face. V1 is ophthalmic division of trigeminal. We will be talking about this in a few lectures. And this ophthalmic is extending to the vertex, the uppermost part of the head, then the maxillary, on top of the maxillary bone, involving part of the nose, lower eyelid, extending to the temporal area, and the mandibular division of trigeminal. What remains is this area here. This area is going to be supplied by a branch of the cervical plexus called greater auricular nerve. This is something we will be going through several times, and you will be asked to test sensations of the face. This is the ophthalmic, maxillary, and mandibular, and this is the angle of the mandible. These are the local nerves of the face, and this is the area where the patient is going to say, I have pain in this area. You know what's this? This is herpes zoster, and you know what is herpes zoster. It's a virus that goes into a nerve, travels through the nerve, and makes skin lesion supplied by that nerve. This is a herpes zoster really demarcating the ophthalmic branch of trigeminal. Again, these herpes zoster lesions are scattered in the area of ophthalmic division. This lesion is extending along what? The mandibular branch of trigeminal. This oriental boy has, although it's not nice to say very, very nice, it is not nice at all, but the distribution is exactly the same as ophthalmic division of trigeminal. If the maxillary is involved, this is an infraorbital nerve, then the patient is going to say, I have pain in these areas. These are the nerves supplying the face, and we will be going through this when we talk about terminal branches of trigeminal nerve. We need to reactivate our knowledge of blood supply to the face, because it is a very good blood supply. That means wounds of the face will heal very quickly, and when we suture wounds, we have to remove stitches much earlier than wounds of the other places. And we're going to use this knowledge. The blood supply starts at the common carotid, external carotid, facial, extending into the face, continuing as superficial temporal, anterior branch, and posterior branch. The facial artery branches off deep to the angle of the mandible, curves around submandibular salivary gland, appears anterior to the masseter, gives inferior labial, goes up, gives superior labial, external nasal, and angular artery. Nerve to masseter. This is a transverse facial, and this is another transverse facial. This is called occipital. Going to the scalp posteriorly, and this is posterior auricular. And because this is the external auditory meatus, this is posterior auricular. This means what? Wounds heal faster. And this means take stitches earlier. This is the action, and this is why we do it. We activate knowledge of the veins and reuse it. Angular vein, ophthalmic arc veins, external nasal veins, superior labial veins, continues as facial vein, inferior labial vein, then the facial vein goes posteriorly, and this is the superficial temporal vein, transverse facial vein, transverse facial, retromandibular, behind the ramus of the mandible. Retromandibular goes down and divides into two branches. The anterior one joins the facial, and they end up in internal jugular. The posterior one joins the posterior auricular and forms external jugular. Lots of arteries in the face. You see around eye orbit, around the nose, around the mouth, and nerve supply is coming from different directions, mainly from branches of trigeminal. This is the infraorbital. This image is showing that you have multiple blue, green, and red nerves, different branches of trigeminal nerve. What's the story of this girl? The story of this girl is she works in a factory, and you know Indian girls, they have long hair, and her hair was caught in a rotating machine. And rotating machine pulls whatever comes in its way. So the rotating machine pulled her face and scalp. She was taken to hospital, and things are put in place. Whoever put this in place had a very good knowledge of his anatomy. And this is a few years later. This is transplantation of the face, auto-transplant. We need to activate our knowledge of facial bones because we're going to reuse it. Trauma is going to produce fractures of the skull. Remember, X-ray of the skull is a combination of lines and bubbles. Lines and bubbles. These lines are margins of the orbit, and you know that. These bubbles are frontal air sinus. This bubble is maxillary air sinus. And lines and bubbles should be compared to one side to the other. If you compare this nice continuous line, lateral margin of the orbit, in this side, it's not nice and normal. There's something wrong with it. If you look at this bubble here, it's not present here. And then this line is not present here. This fluid level in the maxillary sinus is not present here, and this indentation is not present here. So there is trauma to the left side with a depressed fracture of zygomatic and maxillary. This decision of depressed fracture of zygomatic and maxillary comes after studying the lines and bubbles. And the orbit is in danger because zygomatic bone makes part of the lateral wall and the floor, and the maxilla makes part of lateral wall and the floor of the orbit. So this is a serious problem. Now, and we need our knowledge of this part of skull. If you look here, again the golden rule is lines and bubbles, and you see these white lines, they are all continuous. Bubbles are uniform. Then this is what attracts the attention. So this is a fracture of the maxilla. Again, this lesion here is not present here. So there is a pathology in the left maxillary air sinus. So this is what concerns the face. You know what is this? This is hair transplant. Each dot is a bunch of hair follicles put into the skin, taken from other areas in the head which has more dense hair follicles or other parts of the body, and punched into the skin of the hairless area. If we look into the net, how much is this going to cost? It ranges from $5 to $10 a punch, and a person may need minimum 4,000 to more punches. So it's an expensive process. I will be leaving you with a mind map of the scalp on the e-learning. This is normal hair and what looks normal scalp. Closer look at the roots of the hair and the scalp. This is a healthy scalp. This is a wound in the scalp. The scalp wounds are a problem if it's more than 10 centimeters. The patient should be admitted to hospital. Bad wounds of the scalp. You see, the problem with the scalp wounds is that almost in many cases they are dirty. Dirty means they are after road accidents and probably war accidents, and they contain dirt, pieces of clothes, sand, gravel, lots of bad things. In this image, you can see that the upper eyelid is swollen with blackish blood, and this is because the scalp is traumatized and blood sagged down into the upper eyelid. Now we need to explain this. This is a crumbled, crushed hair. This is a patch of loss of hair. It's a common problem. We're going to see this. This is called alopecia. Sometimes small, sometimes large, sometimes multiple. This image is telling me that this is dandruff, dried, oily material. Lots of people complain of this because the scalp contains lots of sebaceous glands. Closer look and you can see this dandruff. Scalp has many sebaceous glands, and if any gland duct is blocked, people develop sebaceous cysts. You see, uniform margin, nothing is irregular, so this is benign. But people usually get frightened that this may be malignant. It is not. This is what raises suspicion. Blackish, irregular elevation, probably bleeding, could be melanoma. This is the site of benign sebaceous cyst, large wound, a hematoma, two hematomas, a boxer with hematoma in the temporal region, a young baby with a hematoma in the scalp, probably in the process of birth but lasted a long time. This is a common complaint, small lymph nodes behind the ear, and the story is typical. Somebody comes and said, they brush their hair or comb their hair a little bit hard, and they introduce infection in the skin, and infection is drained by post-auricular lymph node. This is an enlarged post-auricular lymph node. Again, this is post-auricular lymph node. Post-auricular lymph node. A post-auricular lymph node. This is the story of blood collecting in upper eyelid several days after hematoma. From where is it coming? Descalping is equal death of the person. If you take the scalp out of a person is going to die. This is an evidence that the scalp of this person is dead. These are some of the layers of the scalp. The scalp is not only the hair-bearing area. It extends to the margin of the orbit, to the zygomatic arch, around the ear, and then posteriorly to the superior occipital protuberance and superior nuchal lines. External occipital protuberance and superior nuchal lines. These are landmarks you know on the skull, posteriorly to supraorbital margins and laterally to the zygomatic arch. These are layers of the scalp. It's the skin, connective tissue, aponeurosis of occipitofrontalis and pericranium. This diagram showing the skin, subcutaneous tissue. Subcutaneous tissue has good collection of blood vessels, arteries, and veins and nerves. Then the epicranial aponeurosis of occipitofrontalis. If this is posterior, then this is occipitalis and this is frontalis. And it's an aponeurosis in the middle, tendon in the middle. Then comes loose areolar tissue that allows contraction of the occipitofrontalis, and then the pericranium, the periosteum of skull bones. Now the difference between this figure and this figure is that skin, subcutaneous tissue, and occipitofrontalis aponeurosis is considered as one unit that moves on loose areolar tissue, and then you have the periosteum of bones. skin, connective tissue, epicranial aponeurosis, and loose areolar tissue. And then the pericranium. Scalp stands for these three layers, they act as a single unit. S for skin, C for connective tissue, A for aponeurosis, L for loose areolar tissue, and pericranium for presented by P. Now the skin is thick. We usually think that palms of the hand and soles of the feet are the only areas of thick skin, but we need to add skin of scalp. It's hair-bearing, many sebaceous glands, therefore it is site for sebaceous cyst. I'm sure there is somebody whom you know that develops sebaceous cyst in the scalp and they get frightened that this is bad disease. This is dandruff. Again, you have seen this image. Connective tissue is fibrofatty layer, connects the skin to aponeurosis. And it has lots of vessels and nerves, and there's a problem in the vessels of the scalp. You see, when you cut an artery elsewhere in the body, now the bleeding stops by two processes. Process number one is spasm of the artery. 50% will decrease the lumen, and the thrombus comes and blocks the rest. Arteries of the scalp, they are connected by fibrous tissue to the surrounding connective tissue in this layer, and they do not go into spasm. They cannot. Therefore, they bleed a lot. Now, if the vessels are cut, prevent vasospasm, and the result is profuse bleeding. You will receive a patient with his or her face full of blood, and the clothes are full of blood. You start cleaning, and you will find that this 2-centimeter wound in the scalp. Especially if the wound involves a major artery which cannot go into spasm, so it's going to bleed. Here is the frontalis and occipitalis, and this is the aponeurosis. This is the occipitalis. Now, laterally, the fascia contains the temporalis muscle. These are external muscles of the auricle, which are vestigial in man. The aponeurosis is thin tendinous structure of occipitofrontalis, laterally contains temporal fascia, and the temporal fascia has temporalis muscle. And the subaponeurotic space extends to the upper eyelid. If the bleeding happens in the subaponeurotic space, you will find that after a few days the blood comes into the upper eyelid. Many sources of blood vessels is the ophthalmic artery, superficial temporal, occipital, So we need to reactivate our knowledge of arteries and veins. Here is the story of the big problem. You know these emissary veins of the scalp? They go through little holes into the bone marrow of the flat bones of the skull. And these are called diploic veins. And these veins, they end up in dural venous sinuses. In this case, it can be the superior sagittal sinus. Now, infection can get in from the wound, which is an extracranial, to the intracranial. Therefore, when you read any medical book about scalp wounds, you'll find a sentence that says, clean scalp wounds thoroughly. نظفها كويس. In an attempt, you may succeed, you may not succeed. In an attempt to prevent this process, extracranial infection becomes intracranial. Now, this is the loose connective tissue, and this is the story of emissary and diploic veins getting into the dural venous sinuses, converting extracranial infection into intracranial infection. Now, intracranial infection is difficult to treat. It should not happen. It should not happen. This is the story of emissary veins are valveless, just like veins of the face. Then the story of hematomas. These are the layers of the scalp, and the story of the veins. Then the story of hematomas. We have a suture between two bones. Now, if a hematoma crosses a suture, this is less harmless. Less harm. That means it is not in the subaponeurotic, it's not subperiosteal. Even if it crosses a suture a little bit. But if the hematoma enlarges, once it reaches the suture, it stops. That means it takes the shape of the bone. When it takes the shape of the bone, this means that it is subperiosteal. Subperiosteal means that it is under the periosteum of that bone. In this case, as pressure increases in the hematoma is going to dissect its way from being extracranial, gradually becomes intracranial. Intracranial hematoma is going to press on the brain, and it is a very serious problem. It needs immediate attention. So we palpate the hematoma lightly. It It may happen after any trauma. The pericranium is the periosteum of the skull bones. It is continuous with endosteum and subperiosteal hematoma. Now forms in the shape of the skull bones and does not cross a suture. This is dangerous. The moral is learn the skull sutures. Your knowledge of the skull sutures will decide whether this hematoma of a skull is dangerous, leading to extradural hematoma inside the skull or not. This is a CT scan showing that here is a hematoma that got into the inside of the skull, pressing on the brain. Therefore you see this lateral ventricle is not like the other one. This is a hematoma inside and outside. You see, intracranial hematomas don't go to the outside, but outside hematomas of the skull get in. Again, another example. Now, the scalp has a very good nerve supply. We will go through this when we talk about trigeminal nerve. So, the case of this girl, she had hemorrhage in the subperiosteal space of the skull. That's why the blood reached the upper eyelid. And we need lymphatic drainage. If it is anterior to the auricle, it is the parotid, submandibular, deep cervical. If it is on the posterior part of the skull, it is posterior auricular, occipital lymph nodes, and deep cervical. So there's a black irregular bleeding lesion. Okay, examine lymph nodes of the face and the neck, superficial and deep. Thank you.